Thank you very much. It's really a pleasure to be here. And I guess this is the 22nd year, but I think those of us who have been here most of those years have seen extraordinary progress, which is continuing evidenced by all the presentations. So I'm going to pick up where Saad left off with his wonderful talk. These are disclosures. He mentioned to you that up front, 4 drugs are utilized in the transplant candidates and transplant ineligible patients. I just want to remind you that the Perseus trial that he mentioned, which was daratumumab RVD transplant followed by daratumumab lenalidomide maintenance, in standard risk myeloma, the progression-free survival hasn't been reached, but the median projected PFS is 16 years. That's with a transplant, and he also mentioned to you the IMROZ trial in the transplant ineligible patients, which is the other CD38 antibody isatuximab together with bortezomib lendex with no transplant, and the median progression-free survival in those patients is 9 years. When I started, this PFS numbers were only in the terms of months. So this is extraordinary progress. But I'm going to talk about relapse myeloma because, in fact, myeloma still does relapse in all of those patients. And Saad nicely mentioned minimal residual disease mentioned by flow cytometry or gene sequencing, but in newly diagnosed but also relapse refractory patients, it's very common nowadays to reach a high extent and frequency of response, including MRD negativity, which does associate with improved PFS and OS. He also mentioned the ability now, since last year, to use MRD negativity as an endpoint for new drug approval, accelerated drug approval in myeloma, which is so critical. If we have PFS of 9 years and 16 years, we can't wait together developing new drugs using that marker. So now we have MRD negativity, and I've said that this is one of the best things that's happened in Washington in years. In any event, here is the high-risk, new definition of high risk that he mentioned for you. I tell you it now again and remind you because even if patients don't start with high-risk disease, they progress over time to acquire high-risk genetics. And the one new thing that you might want to focus on here, 17p is high risk, but 1q abnormalities are high risk, but only in the context of what translocation. So there are some details in here, and including evaluation for TP53 mutations as well. So here we are sitting, we have patients whose myeloma has relapsed. You and I have quite a number of options to consider to try to treat each and every individual patient. So we think about frailty status, as Saad mentioned. Are they fit or frail? We think about what are the comorbidities. Do they have heart disease, neuropathy, renal dysfunction? We think about their genetic profile, mentioned on the last slide. But most importantly, I think we wonder what was the prior treatment exposure and to which drugs are the patient's myeloma refractory. And then on the right side of this slide, what is the preference for the patient? Not everybody needs to achieve MRD negativity, particularly the older patients who are really interested in a quality of life, really can have sustained quality of life without MRD negativity. Now, Saad mentioned this too, but I want to mention it in the context of relapse management. We need to put, as he said, your best foot forward, because this slide shows you in transplant or non-transplant patients that as you go from one treatment to the next line of therapy, there's attrition, there's fall-off by many, many reasons, comorbidity, et cetera. But we shouldn't hold back. We should use the most effective therapies early in newly diagnosed, but in this talk, in relapse myeloma as well. So here's the menu of drugs that are available to treat relapse multiple myeloma, and I'll show you this in several different ways. But we're thinking about what is the prior drug exposure and to what is the myeloma still sensitive. So we have combinations that are active in len and bortezomib resistant myeloma, in bortezomib or lenalidomide refractory myeloma. And we have those drugs that are worked in triple class or even penta refractory myeloma, refractory to bortezomib, kyprolis, lenalidomide, pomalidomide, and a CD38 antibody. Now, this is a review from MMSSKI, which has the different regimens that can be used in len-sensitive, len-refractory, and bort-sensitive, or len and bort-refractory. And you can see here that they're in the main triplets. Some of them are pomalidomide-based, some of them are proteasome inhibitor-based, and on the right-hand side of this are the drugs that have been used and are now FDA approved in patients who have had 4 or more prior lines of therapy. At the bottom left of this slide is autologous stem cell transplant, and I think we can't forget about that. If patients haven't had an autologous stem cell transplant, that remains an option. So here are the clinical trials in patients whose myeloma is not lenalidomide refractory. And you can see that they're lenalidomide dex-based as the control, together with daratumumab, kyprolis, isatuximab, or elotuzumab. All of these randomized trials, as you can see in the red, had an advantage in PFS and OS, resulting in their FDA approval. So we have a variety of triplets in this population. We also have a variety of triplets in the patients whose myeloma is refractory to lenalidomide. They are proteasome inhibitor based, as shown on the left, or could be pomalidomide dex based. So in the proteasome inhibitor based, we have bortezomib dex with daratumumab, with selinexor. We also have kyprolis dex with daratumumab, with isatuximab CD38 antibodies. And then on the right of this slide, we have the pomalidomide dex-based combinations, adding either isatuximab, daratumumab, or elotuzumab. The point here is that all of these regimens were FDA approved years ago based on randomized trials showing PFS and in some cases OS advantage. But we have a big menu from which to choose, and in most patients, we can find a regimen that is likely to have a high rate of response that is durable. Because of all of this progress, we have been able to have patients live longer than ever, live long enough to have 4 prior lines of therapy and still have relapsed myeloma. And that's where the CAR T cells first started, in 4 or more lines of therapy. This is the cilta-cel, which is honestly the most effective CAR T cell. This is the first study, CARTITUDE-1, 4 or more lines of therapy. These patients had, as you can see on the left and right, a PFS and OS that's quite remarkable. The median duration of response here was 34 months, and 2/3 of patients were alive and well off treatment 3 years later. Now, that's a clinical trial, but what's so nice nowadays is these new therapies are being evaluated when they get out in the real world, in patients who have renal dysfunction, hypertension, cardiovascular disease. These are the real patients that we see. How do the drugs work for them? And this was recently published in Blood for cilta-cel. The last slide was a clinical trial. This is in the real world. And in the red, you can see the response rates were still very high, 94%, very similar to what the clinical trial was. So that this is an advance that's actually translating into real-world practice. Now, this was because it was so successful in the 4 or more lines of therapy. Cilta-cel was moved earlier into patients who had 1 to 3 prior therapies in the so-called CARTITUDE-4 trial. It was cilta-cel versus a couple of the triplets I mentioned to you, daratumumab Pomdex or daratumumab Veldex. And you can see in the top line here, the CAR T cell was superior to these triplet relapse regimens. I do want to highlight quickly, though, that in this trial, only about 1/4 of the patients had a CD38 antibody as part of their initial treatment. And both Saad and I have said that's now the standard of care. So if a patient hasn't had a CD38 antibody, one of the triplets that I've mentioned incorporating a CD38 antibody should be used, in our view, to treat the first relapse. The times when CAR T cells are used for first relapse is in the really high-risk myeloma. That's the setting, at least in our center, where CAR Ts might be used for first relapse. And here is a comparison that was presented at ASH just a few months ago, and just looking at the MRD rates and also the PFS and OS rates. As you move it earlier from CARTITUDE-4 to CARTITUDE-1, you can see, from CARTITUDE-1 to CARTITUDE-4 earlier, you can see there's a prolongation of both PFS and OS in so doing. The other CAR T cell that is now approved is the ide-cel. This is the phase 1 trial based again in 4 or more lines of therapy patients. You can see that the overall response rate was 81% at the 450 million cell dose, which was chosen for the trials and is the FDA-approved dose for this agent. The issue is it doesn't have the durability that cilta-cel has, at least so far. This, again, is real-world data. The previous slide was the clinical trial. This is real-world data for ide-cel that was presented at ASH. And you can see in the red, the overall response rate is 73%, but the median PFS is only 9 months. So it's not as effective as I showed you for cilta-cel. But just as was true for cilta-cel, so it's true here for ide-cel. It was tested in 4 or more lines of therapy patients first, and then it moved into the earlier 2 to 4 lines of therapy. And in this paper that was published in Blood, the blue line shows you that ide-cel as a CAR T cell used to treat 2 to 4 lines of prior therapy relapse was superior to conventional therapy. And in this example, it was 5 different FDA-approved treatments. The problem here is that the durability was about 11 months in the original trial and 4 or more lines of therapy. And when they moved it earlier, it did get better, but it got only about 13 months. So honestly, so far, cilta-cel is used in the majority of cases in multiple myeloma. Now, there are some new exciting things coming. This is called anito-cel. It has a different construct. It's what's called a D-domain construct, but it's high transfections efficiency, so the purity of the CAR T cells are positive. You can give a lower total dose. And the data that's been shown so far is very similar to that for cilta-cel. In the red, though, is the one feature that we're hoping may actually distinguish this particular CAR T. At least so far, in its early days still, there hasn't been the neurotoxicity, the cranial nerve palsies, or the actual Parkinson-like syndrome that can complicate a minority of patients with cilta-cel. So far here, with this new construct and clinical trials, that has not been evident. There is relapse after BCMA, and so GPRC5D was discovered by Eric Smith, who was at Memorial Sloan Kettering, but we actually borrowed him, and he's now in Boston. They took Babe Ruth from Boston to New York quite a few years ago. But we are lucky we have Eric Smith now, and he found GPRC5D to be a new target on myeloma cells. And shown in the lower right of this slide, in patients who had had prior CAR T cells, this GPRC5D, this time targeted CAR T, worked still after BCMA therapy. And presented at ASH is this GPRC5D CAR T that's coming towards approval. You can see on the left-hand side, very high response rates, and again in the lower right, high response rates even in patients who have had BCMA prior treatment. A little bit about the bispecific T-cell engagers. You know that they bind to the myeloma by virtue of BCMA or GPRC5D or other. They bind to CD3, they bring the tumor and the microimmune system together, hopefully in so doing to get a more potent selective immune reaction with hopefully fewer side effects. The first one approved was teclistamab. 60% response rate, PFS of 11.3 months. It's been used in combination, but when used in combination, we need to be very cognizant not only of whether we can increase the response, but whether the infection risk also might be increased in combinations. The second BCMA-related BiTE, which was approved, is called elranatamab. It's very similar in its efficacy, 60% response rate. What they did in this particular trial was they switched to less frequent dosing in patients who had persistent response. And that's a big theme I want to mention to you. I think it's so important because the infection risks can be reduced and the efficacy mostly maintained when you do decrease the frequency. And just as was true in CAR T, so it's true here in the BiTEs. GPRC5D BiTEs have been tested. There's one FDA approved called talquetamab. Again, it's a 70% response rate, but bottom slide in the red here, this works even in patients who have had BCMA CAR T or bispecific T-cell engagers. So we have a very exciting armamentarium of both CAR T and BiTEs. Now, when we think about patients, and I've been really focused on this for many years, we need to think about analyzing the tumor, but we need to be thinking about the host. So in patients whose myeloma relapses after CAR T or BiTEs, here's a study of what happens to the tumor. In plain English, the tumor target can be downregulated, it can be mutated so there's no binding, or it can actually be genetically deleted. But on the other side is what's happening to the patient's immune system, particularly here when patients are responding, for example, to a bispecific T-cell engager. They have cytolytic T cells, they have MHC class I expression and presentation. With repeated use, they develop exhausted T cells, which express checkpoints. And when you have predominantly exhausted T cells, you're not only doing no more benefit, you're likely doing harm because exhausted phenotype correlates with relapse of the disease and high incidence of infection. So we need to, in the future, not only look for MRD negativity, but we need to also be profiling the patient's cells to inform treatment. Many years ago, we added IMiDs to the BiTEs in a preclinical model. It shows on the top here in an in vitro and on the bottom in a mouse model that if you add lenalidomide or pomalidomide in a dose-responsive way, you can increase the activity of BiTEs, increase cytolytic activity, decrease regulatory T cells, and other activities. So at ASH this year was presented teclistamab together with daratumumab and pomalidomide. Teclistamab, remember, had a 60 to 70% response rate. When you add these agents in, the response rates goes up even higher. For example, 94% in patients with 1 to 3 prior lines of therapy. Same thing is true for talquetamab. You add pomalidomide to it and you get prolonged responses. And because of this idea that resistance happens by downregulating or mutation of a target, the two BiTEs have been alternated by teclistamab and talquetamab. This was published in the New England Journal by Dr. Cohen from Israel, but high response rates and apparently less resistance, time will tell with follow-up, by alternating the targets using two different BiTEs. And there's a new targeted BiTE that's coming, I hope, to the clinic. The target is FCRH5. All of the studies boiled down. It's a 60% response rate, just like the other BiTEs. So hopefully we'll need this because myeloma is relapsing even after GPRC5D. And just to finish with two other new drugs, mezigdomide is a stronger CELMoD. It's an immunomodulatory drug, binds to the ubiquitin cereblon complex, E3 ligase complex, increasing the affinity for Ikaros 1 and 3. It works when pomalidomide doesn't, and it has been presented with dexamethasone, with daratumumab, and at this year's ASH with several other targeted therapies, but it's an oral agent in combination, gets high response rates even after CAR T. And then finally, the immunotoxin, we're going to have our first one in myeloma, I think. It's called belantamab mafodotin. 10 years ago, we did this study showing immune activity on the right and toxic activity on the left. In a clinical trial, this immunotoxin, together with bortezomib dex and the green line, had a PFS of 3 years compared to the control daratumumab. Bortezomib dex, higher MRD rate. So I think it's coming. So here's the summary. Even in relapsed refractory, you can get a high extent and frequency of MRD negativity. Many triplets are approved predicated upon the sensitivity of the myeloma. I mentioned the BCMA CARs and BiTEs, but we also have other new targeted. I think the future is very bright because these immune therapies are only first generation. We have tri-specific agents, et cetera. And finally is we need to profile the tumor and the microenvironment in the future if we want to give the best benefit to our patients. Thanks very much.